Okay, it's Dr. Buford. Can you angle the monitor first? Just a little bit? We're just getting started on your left shoulder. We're looking at things from the back to the front. Everything you see is magnified 30 or 40 times on the screen. The first thing I should mention is your shoulder was very unstable under anesthesia. It would completely come out of joint to the front. And then here's where we saw that dye collect and why we think you had a slap lesion. You can see how that peels away a little bit. But you can also see how the articular cartilage comes right across the top of the glenoid. Your biceps tendon's on the right, and then as we rotate the camera around, you can see a little bit of damage to the attachment, but it's pretty stable. And I think the bigger issue by far is the instability you've got in the front of the shoulder. Let me see a crochet hook, please. The rest of the tip-off here for me is that the edge of this is absolutely rolled and smooth. I don't see any signs of any significant trauma. And I think the reason why this is starting to be damaged is from the recurrent instability. Usually we need about a 4 or 5 millimeter gap before we consider repairing it. And as I tug on it, I'm just not quite there yet. We'll have a look at that in a little bit. Okay, so this is a 4 millimeter diameter shaver, just to give you an idea of how we measure things. So you can see that I cannot slip this shaver down here, which tells me that that gap there that we're looking at is really just a millimeter, maybe 2 millimeters tops. And so for me, that wouldn't qualify as a slap that needs to be repaired. Maybe in a very, very isolated, unique situation, if somebody had no instability and this was the only injury in the shoulder, and we were absolutely certain that this was causing symptoms. But with you, we've got a dislocating shoulder to worry about, and I think that that's going to tighten up this area and prevent that from getting any worse. So as we look down the front, we can see the subscapularis tendon, we can see the middle glenohumeral ligament crossing it at the tip of the great cannula. And the big deal with your shoulder is that you don't necessarily have a Bankart type injury where the labrum's detached, but you do have multidirectional instability where the capsule and the ligaments are loose. So we can see the laxity here in the inferior recess. Okay, so we're going to go ahead and get to work. We're going to start in the back of the shoulder, actually, and we'll show you that in a minute. Okay, so now keep that anterior cannula. So now we're looking from the front to the back. This blue cannula is coming in the back of your shoulder. We've got an instrument in here called a rasp that just roughens up the capsule and the labrum so we can create a healing response, hopefully. The posterior band of the IGL is supposed to be right about here. And you can just see a little bit of it, but we're going to make that hopefully a little bit tighter for you. It's interesting that right at this spot, although the labrum looks good, you've got a little fissure in the glenoid. See that right here? We're not going to mess with that at all. But we are going to put an anchor down here to help with our fixation. Okay, we've got a suture anchor in. We've got 2 sutures here. You can see them there. They're glowing white. As I pull on, I'm pulling very hard, and your whole shoulder's moving, so that tells me that the fixation is good. No, you're right. We're going to go ahead and retrieve one of them, one of the sutures, that is. Pull back on the glue just a shake. Okay, and so now you can see how we've got that arranged, where we've got one suture coming out anterior. There's still one suture going through the posterior blue cannula. And now the next step for us is to go ahead and take an instrument called a suture hook. This is it here. We'll turn on the blue light. Yeah. And so this is loaded with a black wire called the super shuttle. There it is there. We're going to go ahead and start here. We're going to rotate back and go into this capsule over here. See how thin that posterior capsule really is. Now that we have this capsule captured, you can see how we can shift it. See how that tightens the capsule there? And it starts to get rid of this inferior recess down there. So we're going to go ahead and shift and now bring this through the labrum down here. Our first pass under the labrum and through the capsule. I'm just trying to focus a little bit better here. That's Pretty good. And now we're going to do the same thing one more time. Stitch before we tie the knot. Now we're going to tie the knot, and you'll see what that looks like when we're done. So we've tied and cut the suture tails. That looks good. You can see how that's tightened up. Really plicated this posterior band, which is what we wanted. Okay, I'm happy with the way that looks. And now we're going to focus our efforts on the front of the shoulder. That little fissure is interesting, isn't it? I think it's just congenital though. So now we're going to focus on the front of the shoulder here. Pause. Okay, so we've passed and tied the first suture. You can see the cut ends right there. We've got a second anchor in, and we're going to do the same thing with this one, just to really make sure we get the front of this shoulder tightened up for you. Okay, so now we're looking down the front of the shoulder. It looks a lot better. We've got that second suture tied as a simple stitch because you can see we're all the way up at the anterior or superior edge of the subscap, so there's no more capsule here that we'd want to repair or plicate. So we've really worked all the way from this spot in the back of the shoulder all the way around to this spot to tighten things up. I really hope that does the trick for you and takes care of this instability that you've been experiencing. I'm going to put the camera in the back one last time before we finish up, but we're very close to being done. Pump off. So now we're looking from the back to the front, and this biceps looks pretty good. Again, that's not enough laxity to repair. That's really just normal. You can really tell because we can see the articular cartilage as it comes over the superior edge of the glenoid there. Okay, if we have to do a slap, that's typically the cartilage that we have to remove so that we can get things to heal back down to the bone. But I think that's going to be fine based on the reconstruction that we've already done. So hopefully that'll do the trick, and we'll get you back to the recovering shortly. Good luck to you now. Bye-bye.